We are live, Cold Blue, live inside the ER. Dr. Jerisa ER. I am your certified emergency medicine physician. I'm trying to help y'all be good patients. I am your good ER doctor trying to help y'all be good patients. This is another Cold Blue live. We're gonna be doing lives on Instagram because that's where a lot of y'all at. Live on Instagram, Trauma Thursdays. So stay tuned for that. Trauma Thursdays live on Instagram. So when you see that live button pop up on Instagram, check it out. If you're in the ER, you're waiting, you got some questions, you recently got diagnosed, whatever, live, Cold Blue, Trauma Thursdays. Not tomorrow, not this Thursday, next Thursday. All right, this Cold Blue. I want to talk about high blood pressure. I'm trying to set the expectations up for y'all as it relates to high blood pressure in the emergency room. And then separately, because we're going into Thanksgiving, food poisoning. Not really because we're going into Thanksgiving, but really because of this whole buzz with, the beef and beef recall and where the beef, like, thank God we ain't got to eat no beef this week because, well, some of us, because it's like, where the beef? Where the beef? Who got beef? It's recall. We eating turkey, ham, vegetarian. Woo. Um, but I wanted to talk about food poisoning and what you can expect when it comes to the emergency room because everybody be like, I'm dehydrated. I need fluid. I need some fluid. Give me some IV fluid. You vomited once, diarrhea once, and you're like, give me some fluid. I need something. I'm about to pass out. I'm about to pass out. But there is a shortage. There's a shortage of IV fluid. And so most ER doctors right now, hospitals in general, not even just ERs, like even the floor, admitted patients, you put in the order for any kind of IV fluid, and it's like, do you really want this? You get an error message pop up. Does this person really need this fluid? Do they really need this amount of fluid also? Like, is this what you really want to do right now? So there is a shortage because of the hurricanes that we had a couple months ago with a particular company that like produces and supplies a lot of the IV fluid. So let's get into it. We are giving away 3 cash apps this week. What do you got to do? Number 1, you got to subscribe to YouTube. You got to be a subscriber. And number 2, you also got to go to drjerisa.com, scroll on down, and join the newsletter. I ain't trying to be sending out a bunch of emails. Like, I know, like, I be cautious myself when I got to get my email. Like, what you going to do with my email? I will quickly unsubscribe if you be sending me too many emails. Like, for real, like, what's going on? So you ain't got to worry about getting a bunch of emails from me. This is more so stay in contact. You might get an email once a month, once every other month. Happy New Year. That's it. Okay. But yeah, in order to be in the Cash App lottery, you got to do it. You got to do it. So now that the logistics are over, high blood pressure in the emergency room, what can you expect? What can you expect? This is a big one. This could be a lengthy one with just high blood pressure alone because what we do with blood pressure in the emergency room, of course, varies from patient to patient. But many patients that come to the emergency room, one of the most popular questions they have in their mind, because sometimes they don't ask. Y'all patients, some patients, y'all bad patients, y'all don't advocate for yourself. If it's something you won't, say it. Say it. Okay? Don't even think everybody can't read your mind. Can't read your mind. Okay? Just say it. You want blood pressure medicine? Say it so we can address it at that time. Okay? I'll never forget there was a patient, a younger patient. She would get headaches. So of course, common symptoms that your blood pressure may be high: dizziness, chest pain, headache, very common when your blood pressure is high. And then when you're in pain increases your blood pressure, so it becomes like a seesaw. But she would go from ER to ER, urgent care, ER, back, forth, because her blood pressure would never really be high enough. Now, there's hypertension There's blood pressure that's like really, really high, and there's blood pressure that's just not high enough where the emergency room doctor, standard of care, will give you a prescription for anything. We usually would say you have to follow up unless there is a barrier to follow up. You know, this person doesn't have insurance, this person doesn't have a doctor, they're not going to be able to see a doctor for a couple of months. And we have more than one documentation that your blood pressure is really, really high. Okay? Some people just get white coat. You know, it's when you go from place to place to place to place, you seeing this doctor here, then you go see here, you see another ER doctor, then you go see here, you see another urgent care doctor. You all over the place. You're not really establishing a record with one facility where they can see a pattern. And I kind of felt bad for her when I saw her because I'm like, well, this is my first time seeing you. I can't, you say, and I believe you, your blood pressure was that, but I don't have any record of that in the computer system. So I can't just really give you, you know, a prescription for medication because your blood pressure is 160. Yeah, you may need medication, but I can't start you on that medication right now because who's to say next week your blood pressure may be 120 over 80. You don't have a follow-up. We don't typically do that. Most emergency room physicians, unless it's really high, and we'll talk about what's really high, as well as there is some kind of record pattern where we can say, okay, this person has had it in the past. Maybe they had a moment where they are controlled, or this person, they were seen, you know, last month, and oh yeah, their blood pressure was high then. Like something where that ER physician will feel comfortable that it will be safe to go ahead and initiate or start you on a blood pressure medication, and not fear that starting you on the blood pressure medicine might drop your blood pressure too low. That can happen. You start somebody on medication because they have a blood pressure of 160 over 80. They could be stressed. They could have had a salty meal. They could be in line having painful distress and may not really be a hypertensive patient. There's a blood pressure reading that's high, and then there's this patient has diagnosed hypertension. That's the difference. Okay? These are the ones where, yes, we could consider starting you on medication. Blood pressure reading, high, isolated, no really record of that. I'm sorry to tell you, most ER doctors are not going to start you on no medication, especially if there's no pattern. And she got that patient, which I remember, she got so upset. She's like, nobody wants to help me. And I can understand what she was doing because how she felt, because she's trying, she's going all these different places trying to do, you know, but that's the problem. You're going to all these different places. That's the problem. The thing you really got to do right now is get a primary care physician, get established with someone where you can have a record of this. And that person can monitor you, start you, initiate you on the medication. So that is an expectation we got to set. The emergency room may not start you on blood pressure medicine. Okay. Now, the emergency room may give you medication in the emergency room, but then they may not. So let's talk about that, because that also is another one where patients be like, man, I went to the ER, they ain't do nothing, man. I thought they was gonna give me medication. My blood pressure was 170, 180, 190 over 90, and they didn't give me no medication. They just let me walk on out. I'm about to have a stroke. I feel like I'm about to have a stroke, and they didn't give me nothing. They didn't give me nothing. They didn't do nothing for me. It happens. And it's been said so many times, and I get it. I get it. But we have our protocol. And the protocol is for the overall safety of the patient. when it comes to blood pressure. You do not want the blood pressure to drop, and it does. It can happen. It does happen. Ooh, child. And then next thing you know, we give an IV fluid, which we ain't got a lot of. We give an IV fluid and we try to put you in Trendelenburg because your blood pressure is low when you got up and you feel like you're about to pass out. Because the ER gave you blood pressure medicine. They gave me this strong medication. They didn't need to give me this medication. They could have, and then then you're saying the reverse. You're saying the reverse at that point. Because you feel like crap. Because now your blood pressure is low and you feel like you're about to pass out. So that is exactly why we really do have parameters of when we give blood pressure medicine in the emergency room. And I really want to say that I'm not going to talk about parameters. I ain't gonna even say what it has to be because it could be a certain level and we give a pill, or it can be that same level and we may do IV. So that part, there's kind of variation with the ER physician. It really it's the whole clinical picture at that point. Do they have other conditions? What else is happening for us to feel as though we could just do a pill, or we need to establish IV access. Okay. But that's not really what I want to talk about in this video. What I want to set the expectation up for you is knowing that the ER may not give medication, because that's where patients feel as though there's some they don't understand. You feel as though you're about to have a stroke and the ER didn't do anything. But sometimes the best thing the ER could do for you is to not do anything. Hello? Sometimes the best thing the ER could do for you is to not do anything. And that's where this video is trying to help you understand that you may not have been at a level where they would give you medication there. That doesn't mean that you don't need hypertension controlling medication. That ER doctor may not even feel comfortable starting you on medication. You know why? Sometimes we don't even feel comfortable starting patients on diabetic medication anymore because there's so many. There's so many. However, we may start you on a low dose here and ooh, I gotta say this also. We may start you on a low dose medication. And then what ends up happening is you think that's it. This is the medicine I'm on. This is the medicine I'm going to be on. You don't follow up. You stop checking your blood pressure. You think, oh, they gave me a pill, so I'm supposed to be okay. That's what ends up happening. So sometimes even an ER doctor, they may say, okay, we'll give you a week, we'll give you 2 weeks supply, that's it. Because the worst thing that can happen is you get put on a medication and you think that's the medication you're supposed to be on forever. You don't follow up. You're on a medication that doesn't ultimately control, or a dose that does not ultimately control your blood pressure. And then you don't follow up. When probably, had you initially got in with the primary care physician, they discussed the options, they checked your renal function, they talk about the different varieties, and they'd say, okay, we're going to see you again in 3 weeks, adjust the dose. Then that continuity, that follow-up might have been overall just a better course for you. So that's why I say sometimes the worst thing an ER doctor could do is to do something. Sometimes you got to follow up. But the ER doctor, yes, sometimes in conversation with the patient or a patient's primary care physician, because your primary care physician may have their diabetic medication they like, their high blood pressure medication they like to put their patients on. They're taking into consideration your other medications, which sometimes we don't really know all of that. Does this person also have a heart problem? Do they have, we don't check. If you're coming in for high blood pressure, we don't necessarily know you got diabetes also. Well, you might have diabetes or early onset or, borderline, where you may benefit from this medication over the one that ER doctor wants to give you. So that's why I say we stay in our lane sometimes. And sometimes y'all got to understand that the ER is going to stay in their lane But you have to follow up because that primary care doctor can look at all these other things and decide the best pill for you and the dose versus the ER just starting you on something randomly that they would start everybody on, not even knowing you fully and knowing your blood work. It's not just, well, they give me a prescription. You have to be very careful of what medication you start this patient on also. Guys, I'm going to say this. Man, this video was going to end up being long because I got to get into food poisoning. I probably should have separated that. But I want to share this. This patient new to blood pressure medicine. So, never been on blood pressure medicine before. However, there was a record that they had been to the emergency room enough times, that same emergency room enough times, where that doctor felt comfortable starting them on medication. So that doctor ends up starting him on, and that's where I say everybody's different. I wouldn't have done that. I wouldn't have started that patient, number one, on that medication. I wouldn't have started that patient, number two, on that dose. But that's the thing. Every ER doctor is different when it comes to that. So they took the patient was having, they started this patient on a very tiny, the blood pressure was high and it had been documented high for several times. Well, they started the patient on a low dose, a very, very, very low dose. Not just a low dose, a very, 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 very low dose. Okay. And so then the patient came back not even a week later. The patient came back, said they're still having headaches. They feel as though their blood pressure is still high. Well, they didn't see that doctor. I ended up being the second doctor they saw. And I explained to them, I said, well, they don't have a primary care doctor at that time. So they're likely going to go to the ER again and see a third doctor, right? But they were in the process of getting established. But unfortunately, new patient appointments to see a doctor, y'all, I'm just trying to tell you, be prepared. 1 to 2 months. That's the standard. You're not going to be able to see no new doctor in a week. It just doesn't really happen. So please try to understand, the longer you wait, the longer you wait. I said that in another video. That's it. The longer you wait to get established with the doctor, the longer you will wait. Patients come in, I've been dealing with this problem for a year and I can't see a doctor next week. But you've been dealing with it for a year. They told you they'll see you next month. You need to get on the books. Get on the books. Go ahead and set up that appointment. You're not going to get nothing sooner. You're not as a new patient. Rarely, not as a new patient. Okay. So what I told that patient when she came back, I'm like, well, I wouldn't have done this. I would have put you on this dose. But see, this is a problem, right? So now she got the pill with this dose. And I told her, well, you can take 2 of these when you run out. Then I'll give you a prescription where you'll have the new dose that I would start you at. And that's just something you would do in the meantime. Okay. But just letting you know, like there's variations of when the ER doctor is going to start you on medicine. And I already talked about what we look for to see if we're going to start you on medication or not. It's okay or not. Hopefully you're going to follow up. If there's any issue with follow up, then you need to make that be known, because that also can be a consideration and exceptions to if we're going to go ahead and initiate you on a 2-week therapy or maybe a month therapy, but that's a stretch, but it really has to be something where this person is really going to have problems with access to, primary care. And we're trying to create that bridge until you can get in. All right. No, they may not give you medication in the emergency room. No, they may not give you a prescription in the emergency room. And those are the reasons why. And if you want something, you better say something. Okay. Now, moving from that to food poisoning. Yeah, I really should have done two. This should have been separate. Oh gosh, I do have a video on diarrhea. So I recently did a video that's posted on YouTube about diarrhea. So food poisoning. Well, listen, we got the beef issue right now. We got the beef issue. Unfortunately, people have died. People have died from it. And because of that, there has been a recall. So there's been a recall of the beef. That particular beef was causing E. coli infections. And at least I know just the one E. coli infection as a cause of the food poisoning. What I want to really share about food poisoning is you don't want to wait. I think, there used to be a period where if you're having mild symptoms, nausea, some upset stomach, yes, there are certain things you can try, and you should try. That is key. Don't wait to not try nothing. Well, you feeling bad, take something. I don't, you do that. It's okay. You're feeling bad, take something. But some people, you can't afford it. You may not have access. You could feel like crap. Who's gonna feel like crap going to Walmart or CVS, Walgreens to grab something? I get it. So you may want to go ahead and have some of that stuff in the house, so that way you prepared in case of. But yes, certainly, if you don't have it, you don't have it. If you do have access to it and you want to try to avoid the emergency room, then yes, you can take certain medications and you can try. What are those? Over-the-counter medications. You have some diarrhea, it's okay for you to take an anti-diarrhea. It's okay for you to take an anti-diarrhea. And not just one. Not just one. There's some patients be like, oh yeah, I took one Imodium and nothing happened, Dr. Teresa ER. Well, you only took one. That's not even what the instructions say. The instructions tell you to take more than that. You know what I'm saying? Like, you just took one? Okay. Really? But yeah, anti-diarrhea medications like Pepto, try it. Non-brand, store brand, same thing. Bismuth, try it. Imodium, store brand. It doesn't have, it doesn't have to be brand. It could be store brand. Try it. One is not going to be enough. Sometimes, you got to take two, or you take it with every loose stool. Sometimes it says that. Follow the instructions for what it says. But it's okay. Yeah, try it. It's also good to kind of keep mind of what you might have ate. What did you eat that could have caused it? That helps, especially now, with the exposure risk. Those are some of the things that we look at. So if someone says, oh, okay, well, I ate this and then 2 hours later I felt this way, that helps us think about certain viruses and bacteria. Okay, or I had this, I haven't eaten anything since last night or yesterday morning. It kind of helps us rule in and rule out certain bacteria and viruses. So what you say matters. What you say matters. What you can remember to say matters. Okay. We look at things like your vital signs. Not everybody that comes in, not everybody that comes in needs IV fluid and medication. I hate to tell you, but not everybody that comes in needs that. However, there are some cases where patients come in and they have been vomiting a lot, where they have had numerous amounts of diarrhea, not responding to the medications that they tried, and they're feeling lightheaded. I'm about to say tachycardic, but they have a fast heartbeat. They feel like they're about to pass out. Like all those things, those are the indications where we would check things like kidney function, electrolytes like potassium, and give that person IV fluid. Now, you can always advocate for yourself. I always say it. Ask for what you want. Ask. Well, have not, ask not, have not, like it's okay. Ask for what you want. I would. There's nothing. I remember a case where the patient and the patient's wife clearly had something in mind that they wanted, but they didn't share that specifics. So they came in with their complaint, not complaint like that complaint, but a symptom issue. And I addressed the symptom issue the way I would address a symptom issue, but they wanted this test done. They wanted a particular test done, but they never said it. So the test, now the test didn't need to be done. I wouldn't order. I didn't order the test because it didn't need to be done, but they wanted it. They wanted it. Well, sometimes, you know what? If you demand certain stuff, you might get it. It might be an absolutely unnecessary cost. But sometimes, you might get it. Depends on the doctor. Man, this patient and their wife decided to go call the family, and the family calling and like, oh, Dr. Teresa, she should have done this test. I'm like, wait, what? All they had to do was ask. Instead, you're gonna call your daughter doctor, or your daughter's husband's doctor, daughter, husband, cousin's doctor, to try to get on me because I didn't order this test that the husband's doctor-in-law felt as though you should have had this test. All y'all had to do was ask. You could have asked that when you came. Ask not, have not. You could have asked. Anyway, did the test. Of course, the test was negative. But I say that to say it's okay to ask for what you want. If you want fluid, if you say, you know what, I'm sorry, I really feel weak, dizzy, I really don't want to leave here, I'm scared, I'm gonna pack it. Like, just ask. Speak up. Speak up. Ask. Advocate for yourself. If you don't do it for yourself, nobody else is gonna do it. I'm telling you now, especially in 2025. Listen, nobody else is gonna do it. Advocate for yourself. You know yourself. You know your body. Don't leave the emergency room without having your questions answered. Don't leave with a sense of uneasiness, or you're just feeling like something ain't right. Like, just say it. Because we can't read your mind. In some of these emergency rooms, thank God I don't really do, some of these emergency rooms are getting really busy. And I'm concerned going into 2025, what's going to happen when there may be, doctors that are, people may lose their insurance and doctors may not be available. I don't know. Who knows? I'm just concerned about Project 2025 and, insurance that people may lose. Research may be lost. Those are some of the things that I think about moving into 2025 with Project 2025. But advocate for yourself. Ask. Food poisoning. Not everybody's going to get IV fluid, especially like now. I mean, I've done probably videos, I don't know if you've seen, where I've talked about there's a shortage with IV access, IV fluid. And so doctors have to be mindful who they give IV fluid to, when and how much. Because after the hurricane, the company that mass produces a lot of these IV fluids, their facility was damaged. They are up and running. They are getting back on track. But that error message can still pop up when a doctor gets ready to order any kind of fluid. So be mindful that vomiting and diarrhea, when you, I hate to say only, because that word can be, it can make it sound like I'm minimizing something, but I'm not. If you only have diarrhea without vomiting, because vomiting, that's a whole different thing. Vomiting, you can't keep nothing down. Diarrhea, you think you're not keeping nothing down, but you actually are keeping some stuff down because you're not vomiting your guts up. Okay. Diarrhea only, you may not get fluid. You may get medication, prescription, especially if you haven't tried anything. No, those medications can also be prescribed. So just like Tylenol, Motrin can be prescribed, you feel like you can't afford it, absolutely, it happens. Medications like Imodium can be prescribed. Okay, so I just wanted to say that because maybe your insurance might cover it if you can't afford it. All right, they can be prescribed. Try those medications for diarrhea. Now, if there's vomiting, we do look at that differently because unfortunately, this patient ain't gonna be able to keep down that medication. So we do have to determine, though, does this patient need IV? You may not need IV access because there are some medications that dissolve right in your mouth. I always keep them. Zofran, listen, dissolvable Zofran, amaze balls. Okay, it dissolves right underneath your tongue, right inside your mouth. You can give it to kid, age appropriate, but it is available for toddlers and kids. For diarrhea, it's not much for that. I hate that with pediatric patients. But they have improved though. There are pediatric anti-diarrhea medications. Please look at that. They are available. They are available. I want to say the age is like 5 and up, but double check that. But they are available over the counter. You don't need a prescription. Okay, you can try it. But now, if there's certain things where you've been outside the country, you've been exposed to something like some bad beef, okay, then that's different. You may need medication, you may need prescription medication, you may need IV fluids. So we really look at to see how long this person has been dealing with diarrhea, how many episodes they're having. That actually does matter. What I'm going to say about diarrhea, I said in another video that is recorded, but diarrhea, it's not going to go away like that. The biggest thing people can think that happens with diarrhea is, oh, I had 10 episodes and it's supposed to be all gone the next day. No. Sometimes diarrhea, it goes from 10 episodes on Monday. Tuesday, you might have 8. Wednesday, you might have 4, and they still be watery and loose. And then Thursday, you might have 2, but you still think you about to pass out and die, but you're not realizing that it actually is getting less and less and less, which is a good sign. Okay, it's not going to go usually from 10 to 0. Usually it's going to be an incremental decrease. Okay, usually, not always. Okay, I mean, yeah, God bless you. You go from 10 to 0, great. But usually it decreases as your body adjusts. Certain things you can also try is yogurt. If you're not vomiting, you can try things like yogurt as well. It has what we call the good bacteria. The gut bacteria that helps restore the normal gut flora. All right. That's the main thing I wanted to say about the diarrhea without vomiting. Diarrhea with vomiting. Yeah, you pretty much got to come to the emergency room for sure with that. Like, there ain't nothing you probably going to take is going to work, especially if you don't have any prescription or anything like Zofran or something that you can try at home. to help, then you definitely want to come in. And they may give IV, or they may give oral dissolvable Zofran, and see how you do. It all depends on how the person presents when you come. Do you look a hot mess, like lightheaded, dizzy, sweaty, diaphoretic, pale, low blood pressure, fast heartbeat? Are you presenting like a patient that really could benefit from fluid? Or are you presenting like a patient that may be kind of mild to moderate, and maybe we could give you some Zofran dissolvable, see if it helps. Not just give it to you and discharge you. Give it to you, see if it helps in the ER. And then if it does, give your prescription to continue, go home, and then add your over-the-counter medication. All right. So that's food poisoning. Why do people die from it? Why do people die from it? The biggest thing as it relates to something like food poisoning certainly would be electrolyte abnormalities. So electrolyte abnormalities that perhaps may cause kidney issues. Okay. And then unfortunately, the person may also become septic or have an overwhelming infection. So those are some of the things that that could potentially happen. Perhaps the patient, they could have suffered, from underlying conditions. Maybe they did or did not know. Because most patients are able to fight through it. Most overall healthy patients are able to do fine. But if you do have something like diabetes, or if you're high risk and you have a history of liver problems or kidney problems, heart problems, certain autoimmune conditions, cancer patients, you are a little bit more high risk because it is bacterial. It still is bacterial. And so something like, because just seem like it's dehydration, might actually be something like a really bad bacterial infection that you probably needed antibiotics for. Okay, IV fluid, Zofran, regular, and vinegar, that ain't gonna be enough. You really likely might have benefited from stool testing. So if you're able to give stool specimen, that always helps. Be prepared. Some patients get like, man, I don't know. I've been having diarrhea all day. I come to the emergency room and I ain't got no diarrhea. It always can help if you can give a stool specimen, because that can be tested. It can be tested to see if it is something like an E. coli, or if it's not. If it is something like, of course, bacterial infections, then that's when you get antibiotics. These things that's happening now are kind of rare, right? But the benefit of when you have these outbreaks is it brings about public awareness, and physicians like myself can educate patients more on what signs and symptoms to look for, and when you should consider coming to the emergency room, what you can try at home. All right. This was longer than it needed to have been. What is this? How long is this? Okay, looks like it's only 40 minutes. Okay, not bad. Not bad. All right. I'm Dr. Teresa. I am your good ER doctor, trying to help y'all be good patients. Cash App. You got to subscribe. And you got to go to drteresa.com, scroll on down, and join the newsletter. I ain't trying to send y'all a bunch of emails. I ain't trying to do that. You might get an email. You ain't going to get no email already. You ain't going to get no email probably the rest of the year. I don't like to get a bunch of emails myself. I will quickly unsubscribe. Quick, fast, in a hurry. Unsubscribe. If somebody's sending a bunch of emails or texts, I'll be like, opt out. Stop. So you ain't gotta worry when you put your email in that you're gonna be getting a bunch of emails from Dr. Teresa ER. No, ma'am, no, sir. So listen, we will be doing Trauma Thursdays. Trauma Thursdays will be live on Instagram. Trauma Thursdays. So if you see the live button pop up, because most of y'all, a lot of people are over there. So we'll be doing some lives there. If you're in the ER, you got some questions, you recently were told this or that, you want to just, yeet, skeet, whatever. Thursdays, live, Trauma Thursdays over on Instagram. I don't know if we're going to do Facebook, but I know we're going to do Instagram. So that's it. I will see y'all on the next Code Blue. Happy Thanksgiving. Don't eat too much. I ain't gonna say nothing else. We ain't gonna jinx nothing, but because we know the title of this video, so yeah, we just gonna keep it like that. We're just gonna keep it like that, and now you're prepared. You're prepared, no matter what happens. When you eat the food, you're prepared. You're gonna be all right. Next time.